Cardiovascular medications. This is the last lecture of the cardiovascular series. This is chapter 20 in your textbook. Class 1A antidysrhythmics block fast sodium channels. They decrease repolarization by stabilizing the cell membrane. For example, quinidine and procainamide. They work best with ventricular dysrhythmias and or fast atrial rhythms. They lengthen the duration of the action potential, so it prolongs the QT. So that does put your patient at risk for torsade de pointe. There are some other examples such as disopyramide or Norpace. It has a questionable real effect on atrial rhythms, works really well with ventricular. Quinidine can be IM, oral, or IV. Maximum dose is 16 milligrams per minute, and it must be protected from light. Procan can be IM, IV, or oral. It's diluted like lidocaine, 1 gram in 250, or 1 gram in 500. And it's administered similarly, except that you can go up to 6 milligrams per minute without a problem. There's a table on page 543 that shows the different classification of your antidysrhythmic medications and the effects of your adrenergic receptors. So you'll want to look at both of those. Your class 1B block your fast sodium channels. They increase repolarization. An example is lidocaine. It's administered IV only. It must be on a pump. And your maximum dose is 4 milligrams per minute IV. If you're going to give it as a bolus, it's 1 milligram per kilogram to a maximum of 100 milligrams. And then you can repeat within 5 minutes a half a milligram per kilogram to a maximum of a total of 150 milligrams. So if your patient only weighs 75 kilos, the first time you only give 75 milligrams. And the second time you give 37 and a half. So you need to know your patient's weight to do it appropriately. Mexatil is an oral lidocaine that can be given, and there's another form that's out there called tocanide or Tonacard, and this is oral only, and it can be given with food. Mexatil, I believe, is still under protection, so that there is not a generic for the Mexatil. Your class 1C block your fast sodium channels. They slow AV conduction. They prolong your QRS duration, so that means they are proarrhythmic. They can cause torsade de pointe. Encade or encanide is not available in the United States because it caused VTAC in a lot of patients, but if you have a patient who's well controlled on it, you can get it. All the doctor has to do is fill out forms for the government. And then again, you can always order it through Canada. Flecainide is also called Tambocar. It is oral only. And propafenone is also called Rhythmol. It is a negative inotrope, and it is also oral only. Your class 2 are your beta blockers. They block your beta receptors. They treat your supraventricular dysrhythmias. Selective esmolol or Brevibloc is an example. It is 500. It is IV only. It is 500 micrograms per kilogram as a loading dose. Your maximum is 200 micrograms per kilogram per minute as an IV infusion. It has a 9-minute half-life. So you can give this as an IV push and the effect is gone within 9 minutes. Dose selective, like metoprolol or low pressor, means that in the higher doses it also blocks your beta-2 fibers. It's non-selective as your propranolol or Inderal. Low pressor treats SVT, hypertension, angina. It can be oral or IV, and you can take it 5 milligrams every 2 minutes times 3, which is the way it's usually ordered IV, and then the next day they get 50 milligrams in orally. Class 3 drugs, slow repolarization. They prolong the duration of your action potential, and they are proarrhythmic. So you have to use some care with them. Anything that prolongs the duration of your action potential is proarrhythmic. You've got amiodarone, which is oral or IV. The trade name is Cordarone. It has a half-life of anywhere from 13 to 107 days. It takes at least 2 weeks to onset orally. If you're giving it IV, only 2 hours. Side effects are not nice. It can cause acute respiratory distress syndrome, pulmonary fibrosis, heart failure. It is a proarrhythmic. It can cause liver function abnormalities. It has a side effect called, lovingly by the nursing staff, the Smurf effect, in that it turns the skin color blue, just like the little critters that lived under the mushrooms on your cartoon days when you were a child. Foot causes photosensitivity, dizziness, malaise, anorexia, nausea, vomiting, constipation, ataxia, which is a problem with your gait, paresthesias, numbness and tingling, and poor coordination. So amiodarone is not necessarily a drug that should be used first. If you have known heart disease that did not respond to lidocaine, yes, you will start with amiodarone. If you have no known heart disease, you will start with lidocaine. That is a reversal of the way in which it was done about 5 years ago, but it is better for your patient. Ibutylide is also called covert. It is IV only. It is for rapid atrial cardioversion. Side effects are headache, nausea, and dysrhythmias. Sotalol is also called beta-pace. It is given orally only. Beryllium is IV only. It is a third-line drug for ventricular dysrhythmias, and it is not currently available in this country. Dofetilide, or Ticosin, is given to convert atrial fibrillation to atrial flutter. Atrial fibrillation and atrial flutter back to a sinus rhythm. Your class 4 calcium channel blockers, you've got your nifedipine, diltiazem, verapamil, and nicardine is a new one. They treat supraventricular antiarrhythmics. There's a table on page 548 that shows the different types, their dose, and their side effects. Your unclassified antidysrhythmics like adenosine or adenocard slows conduction through the AV node. It treats supraventricular tachycardias. It has an extremely short half-life. It's eliminated totally from the body in 10 seconds, so it's really short. You give this rapidly IV push. Magnesium we've talked about already. It is an electrolyte, and it is the treatment of choice for torsade de pointe. There's a table on page 545 that talks about the indications, dose, and side effects of many of these drugs. You'll want to look at that. Inotropic agents are your cardiac glycosides like digoxin and digitoxin. Digitoxin is the oldest form. The nice thing about it is it is secreted through the bowel. So if you have somebody who's in renal failure, you could give them digitoxin. Digoxin is excreted in the urine. So if you have somebody in renal failure, you have to give a less than usual dose for that. Your catecholamines are your dopamine, epinephrine, norepinephrine, dobutamine, and isoproterenol. Dopamine, epi, norepinephrine are all produced by the body, by the sympathetic nervous system, and also by the adrenal medulla. Dobutamine is converted to dopamine within the body. Isoproterenol or Isoprel had not been available in this country, but it works really well to increase heart rates. There's a table on page 547 that shows the physiologic effects of your sympathomimetics, and on page 548 your vasodilator dose for pre and after load treatment and your side effects. Your phosphodiesterase inhibitors increase intracellular calcium, increase the levels of your cyclic AMP, thereby it increases your cardiac output, it increases your contractility, and it decreases your afterload because it causes vasodilatation. There are different types. You have amrinone or Inocar, which can cause thrombocytopenia, and you have milrinone or Primacor, which causes ventricular tachycardia. Both of these are given IV because phosphodiesterase inhibitors are only given IV. Your vasodilators can be either direct acting, such as nitroprusside, nitroglycerin, apresyline. They decrease the peripheral vascular resistance because they relax vascular smooth muscle. Nitroprusside can break down to cyanide, so you don't want to infuse it for long periods of time. ACE inhibitors and calcium channel blockers are also vasodilators, and your alpha blockers such as labetalol and regitine. There is a chart on page 548 for the different drug characteristics. Your B-type natriuretic peptide, nirceratide or Natracor, treats heart failure by decreasing systemic vascular resistance, peripheral vascular resistance, filling pressures, and increasing urinary output. It's administered as 2 micrograms per kilogram IV bolus, followed by 0.01 microgram per kilogram per minute as a continuous IV infusion. Side effects are hypotension. There's a table for this on page 550. Your DA1 receptor agonists like phenoldiprem or chlorlapam, they're selective specific dopamine DA1 receptor agonists. At low doses, their effects are similar to low-dose dopamine. It's given IV 0.03 to 0.5 micrograms per kilogram per minute. You can use it for patients who are in renal failure. Vasopressors stimulate your alpha receptors. They increase systemic vascular resistance, and they increase your blood pressure. So they also increase afterload. You can use neosynephrine or Levophed in septic shock patients. Levophed actually has been shown to work really well with sepsis. It does increase the workload of the heart, and if they do infiltrate, they can cause sloughing of the tissue, so you have to use a central line. There's a table on page 548 for the specific vasopressors to look at. And this is just a brief overview of the medications for the cardiovascular system. Thank you.